Hormonal acne. This is the most common type of acne in adult women, and it follows a pattern that is almost clockwork once you know what to look for. It appears primarily along the lower face, the jawline, the chin, and the neck. It tends to arrive in the week leading up to menstruation, when estrogen levels fall and androgens, the male hormones present in every woman's body, become relatively more dominant. These androgens stimulate the sebaceous glands to produce more oil than the skin can clear, and that excess oil becomes the foundation for breakouts. What makes hormonal acne particularly frustrating is that it tends to sit deep under the skin rather than coming to a visible head quickly. The lesions are often tender to the touch before they are even visible on the surface. Standard acne products aimed at surface-level bacteria do very little for this type because the origin is internal, not topical. Addressing the hormonal environment, whether through dietary changes, stress reduction, or medical support, is what actually moves the needle. Cystic acne. Among all acne types, this one causes the most significant and lasting damage to the skin. Cystic acne forms when a pore becomes so deeply blocked and inflamed that the infection essentially turns into a fluid-filled sac beneath the skin. These cysts are large, painful, and almost never come to a head on their own. Attempting to squeeze or extract them pushes the inflammation deeper, which almost always leads to scarring. It is significantly more common in women with hormonal imbalances, and it frequently appears alongside conditions like PCOS. The skin around a cyst often looks red and swollen beyond the cyst itself, a visible sign of how widespread the internal inflammation is. Cystic acne can persist for weeks on the same spot and leave behind dark marks or pitted scars long after the cyst itself has resolved. It is the type most likely to require medical treatment to address effectively. Comedonal acne. This type is the most widespread and the least understood. Comedones are the small, non-inflamed blockages that form when excess sebum and dead skin cells clog a hair follicle. When the clogged pore is open at the surface and the contents oxidize and darken, it becomes a blackhead. When the pore is closed over by a thin layer of skin and the contents remain white or flesh-colored beneath, it becomes a whitehead. Neither type involves bacterial infection at the stage they first form, which is why antibacterial cleansers have limited effect on them. What drives comedonal acne is a combination of excess oil production, sluggish skin cell turnover, and in many cases, the use of pore-clogging skincare or makeup products. The nose, forehead, and chin are the most common sites because sebaceous gland density is highest in those areas. Consistent exfoliation and oil regulation are far more effective for this type than any antibacterial approach. Fungal acne. Despite being called acne, this condition is not caused by bacteria and does not respond to any standard acne treatment. Fungal acne is actually a yeast overgrowth in the hair follicles, caused by a naturally occurring fungus called Malassezia. It presents as small, uniform, itchy bumps, most commonly on the forehead, chest, and upper back. The uniformity is a key distinguishing feature. Unlike bacterial acne, which produces breakouts of varying sizes in different stages, fungal acne tends to look consistent, like a rash of similarly sized small bumps clustered together. Prolonged antibiotic use, excessive sweating, wearing tight or non-breathable clothing, and a diet high in refined carbohydrates and sugar all create conditions where this fungus thrives. Because it is so frequently misidentified as regular acne, many women spend months using products that make the condition actively worse without understanding why. PCOS-related acne. Polycystic ovary syndrome creates a hormonal environment that is exceptionally prone to acne, and the breakouts associated with it have specific characteristics that set them apart. Because PCOS involves chronically elevated androgen levels rather than the temporary androgen dominance of a normal menstrual cycle, the acne it produces tends to be persistent rather than cyclical. It does not reliably clear up in the second half of the cycle the way standard hormonal acne might. The breakouts are typically deep, cystic, and concentrated along the jawline, cheeks, and chin. Women with PCOS also notice that their skin is significantly oilier overall, not just just in the area of active breakouts. Insulin resistance, which is present in a large proportion of women with PCOS, plays a direct role in driving excess androgen production, which is why blood sugar regulation through diet has a meaningful impact on the skin in this group specifically. Stress acne. The connection between skin and stress is both real and measurable, and it works through a specific biological pathway. When the body is under sustained stress, cortisol levels remain elevated. Cortisol stimulates the sebaceous glands to increase oil production, thickens the oil so it is more likely to clog pores, and simultaneously weakens the skin barrier that normally keeps bacteria from causing infection. The result is breakouts that seem to appear at the worst possible times, before an important event, during a period of major life pressure, or after a stretch of poor sleep. Stress acne tends to appear in the same areas as hormonal acne, primarily the lower face and chin, because both are driven by similar androgenic signals. Reducing cortisol through sleep, movement, and genuine recovery time is not optional skincare advice. For stress-driven acne specifically, it is the core treatment. Perimenopausal acne. Many women are caught entirely off guard when acne returns in their 40s after years of clear skin. Perimenopause, the transitional phase leading up to menopause, involves significant hormonal fluctuation. Estrogen levels become unpredictable, rising and falling without a clear pattern, while progesterone also declines. As estrogen falls, the relative androgenic activity in the body increases, which creates a skin environment that begins to resemble adolescence in some ways, with higher oil production and a greater tendency towards inflammation. The acne that appears during perimenopause tends to be deeper and more persistent than the surface breakouts of teenage years, and it often responds poorly to the products that women may have used successfully at an earlier age. The skin is also losing collagen and elasticity simultaneously, which means that the inflammation from acne takes longer to resolve and is more likely to leave lasting marks. Maskne. The widespread use of face coverings over recent years introduced a new category of acne into mainstream conversation. Mechanical or friction acne, now commonly referred to as maskne, develops when fabric sits against the skin and creates a combination of heat, moisture, friction, and occlusion. This environment traps sweat and bacteria against the skin, softens the outer layer of the skin barrier, and creates the conditions for both comedonal and inflammatory breakouts. The areas most affected are the ones in direct contact with a mask: the chin, nose bridge, cheeks, and jaw. Even women who had previously clear skin began experiencing breakouts in these specific zones after consistent mask wear. The same principle applies to other forms of skin contact: sports helmets, headbands, phone screens held against the cheek, and chin straps, all of which can produce localized breakouts along contact lines. Diet-triggered acne. The relationship between food and acne was dismissed for decades in mainstream dermatology, but a significant body of research has shifted that position considerably. Certain foods create conditions in the body that directly encourage breakouts. High glycemic foods, those that spike blood sugar rapidly, trigger a cascade that raises insulin, which in turn raises androgen levels and increases oil production. Dairy, particularly skim milk, has been consistently associated with acne in multiple studies, likely due to its growth hormone content and its effect on insulin-like growth factor in the body. Whey protein, a common supplement among women who exercise, is another well-documented trigger. Breakouts driven by diet tend to appear on the cheeks and forehead and respond quickly when the triggering food is removed, often within a few weeks, which makes dietary elimination one of the most informative diagnostic tools available. Skincare products causing acne. This type has a specific clinical name, acne cosmetica, and it's far more common than most women realize. It develops when certain ingredients in skincare products, moisturizers, sunscreens, foundations, primers, and hair products, block the pores or irritate the follicle lining. The resulting breakouts are usually small, flesh-colored bumps rather than deep inflammatory lesions, and they appear consistently in the areas where a specific product is applied. Forehead acne that that worsens after a new moisturizer, or hairline breakouts that correlate with a particular conditioner are classic presentations. The challenge is that many products marketed specifically to acne-prone skin still contain ingredients that are comedogenic for certain skin types. Identifying the triggering product through a systematic elimination approach and switching to genuinely non-comedogenic formulations is the only reliable solution.